Good afternoon and welcome everyone. Thank you all for joining us today. So we're excited to get things started. We're just a few moments after the hour and we will probably conclude a little early today, but we're happy to give you back some time if that works out that way. So Nikki, do you wish to kick things off for us?
Sure. So again, thanks for joining the Payer Telehealth Town Hall. I'm Nikki Majewski with the Maryland Healthcare Commission, and joining me is Mr. Ben Steffen and David Sharp. Before we get started, I just have some general housekeeping items to go over. The town hall is being recorded, and the recording will be available on MHCC's website. In the event there is a technology failure, we'll be in touch with everyone as soon as possible, stating whether you should join again via the existing link or send out a new meeting link, or if we should need to reschedule, we'll let you know. Due to the number of participants on the call today, we will not allot time for individual introductions, but a list of the attendees will be posted along with the recording on our website. We'll also ask participants to remain muted until you're called upon to speak. MHCC staff may mute you should we pick up some background noise. Please signal to us that you would like to speak by using the raise your hand feature at the bottom. MHCC staff will sequence participants to make comments, starting with those who requested speaking time. Please be sure to lower your hand once you've commented. And then lastly, speakers are encouraged to identify themselves first, stating their name, organization, and a little bit about what they do and the stakeholder groups they may represent. And you're welcome to use the chat function in the event there are too many comments to acknowledge or address. We'll post a response to the website with the recording. Also want to note, we'll note again later at the end before we conclude, that we'll be accepting written comments through July 21st, which happens to be tomorrow, but comments will be posted on our website as well. And should you have any technology issues, you probably received an email from my colleague, Kelly Scott. Her contact information is there, so you can reach out to her if anything should happen that you need some technical assistance with today's webinar. So I'll pause here and then ask Ben and David to make a few opening remarks. Ben, are you able to chime in at this time?
I actually don't see him connected at the moment, so let me start and we'll plug Ben in as soon as he's able to join. Taking this out of sequence a little bit, I think what some of you have participated on the prior town hall event we had for providers, which was last Thursday, if my recollection is correct. And it was very successful, and we heard a lot of really good comments about that event. Today's event, we're structuring it just a little different because last week we had lots of providers who wanted to talk. Today, we have three representatives from carriers that have signed up to make comments. So what we'd like to do is open it up to more of a roundtable discussion after the commenters have had a chance to speak from the carriers, and try to look at the questions we asked in the last slide, near the last slide, a few what we would call roundtable prompting questions and we will invite any of the participants here today to give us their views related to either what they've heard today on the roundtable discussion or their views on the areas of interest noted in the slide. So we're very excited to kick things off. We're very excited to hear from everyone who wishes to make remarks, and we're looking forward to getting things moving. So our executive director, Mr. Ben Steffen, has been able to join us, and we will invite him to make a few opening remarks.
Sure. Thank you, David. Like our provider, telehealth Town Hall last week. I see we have a lot of attendees. I want to thank you all for taking time out to give us your comments. We're very interested in input from the carriers. We recognize that telehealth is evolving, and as we begin to think about that final report required under Senate Bill 3, House Bill 123, that this input will be valuable as we consider recommendations in the final report. So thank you, and I want to recognize all the work that the Center for Health Information Technology and Advanced Care Delivery has made in this area over the last year and a half. It's been a challenge at times. I also want to thank our consultant NORC for their work, but we're nearing the home stretch. So thank you, everyone, and look forward to your frank comments.
Very good. Thank you, Ben. Nikki, so why don't you take us through some of the slides and we'll get to the invitations for the presenters.
Great. Well, just to elaborate a bit more on what David said, we had a great provider town hall. We really appreciate the contribution of stakeholders in helping inform the study approach required by the Senate bill that Ben just mentioned. Your feedback has helped advance the study a good bit. So before we dive into the discussion, wanted to just sort of say that today, you know, as David mentioned, we want to sort of hear from you, and the intent is to sort of build awareness among stakeholder viewpoints regarding use of telehealth and inform those study activities pertaining to the telehealth landscape in Maryland. A little bit more about the study. We prepared a few slides to just highlight progress to date as it relates to the telehealth study that MHCC has been tasked with to complete by the end of this year. This study requires MHCC to evaluate the impact of telehealth with a focus on audio only and audiovisual technologies for somatic and behavioral health interventions. In June of last year, we had released an emergency request for proposal, and in September, an evaluation panel consisting of staff and some external reviewers competitively selected NORC. The law does require MHCC to develop recommendations on telehealth coverage and payment levels relative to in-person care and submit these to the Senate Finance Committee and the House Health and Government Operations Committee by December 1st of this year. Wanted to also note a few study activities on the horizon based on another request from the HGO committee that asked MHCC to study ways to expand interstate telehealth. This study will assess some key considerations as it relates to insurance, interstate compacts, and licensure to inform development of recommendations, which are due at the end of next year, 2023. And WSTAT was competitively awarded to conduct this study. Just to sort of jump back to the study underway real quick to overview some of that progress I mentioned, this sort of highlights some key accomplishments, which includes over 1,000 responses to a provider telehealth survey, interviews with English and Spanish speaking healthcare consumers in Maryland, an analysis of government and private payer claims, 2 focus groups with subject matter experts in behavioral health, and a literature review identifying many abstracts that looked at the impact of telehealth. I also want to draw your attention at the bottom of this slide to a dedicated webpage that helps keep stakeholders informed about the telehealth study. Some of you may know, some of you may have been already subscribed to the updates that we post periodically. So the link is included at the end of this slide, and we'll send it in a follow-up email in case you don't know about it yet for your reference. So that concludes the slides. I suppose we should just jump right in and ask the first speaker to present. Just a reminder, speakers are encouraged to identify themselves first, state your name and the organization, a little bit about yourselves before you get started. So Devi, is that a Devi? I hope I didn't mispronounce that too bad. Are you available?
No, I am available, and my name is Davy, like you would say David, Davy.
Oh, great, I'll remember that, thank you. So take it away.
Thank you. I am from Kaiser Permanente. My name is Devi Vijayakumari, and I represent Kaiser Permanente from the product organization. So I'm in charge of developing insurance products for the Mid-Atlantic region. And Kaiser Permanente thanks MHCC for the opportunity to provide our perspective on telehealth and our experiences so far with telehealth. Telehealth is one of the ways by which Kaiser Permanente continues to transform member experience with a spectrum of convenient options to access care. By offering communication technology to bring the delivery system to patients, telehealth can connect patients with providers in many clinical settings, including primary care, specialty care, urgent care, and more. So equal access to virtual care is central to KP's mission of providing high quality care to everyone, regardless of who they are, where they live, or what language they speak. Our virtual care services help remove barriers to care and improve equitable healthcare. And we do so by expanding access to older members and underserved communities, eliminating barriers such as travel or the need to take time away from work or home, providing care in many languages. Kaiser Permanente has invested in telehealth for decades, and our proven infrastructure has rapidly scaled to meet the rising demand during the COVID-19 pandemic. Our integrated telehealth capabilities make it easy for most members to receive high-quality care while staying safe at home and are an important part of how we deliver care. In 2019, video and phone visits accounted for approximately 15% of ambulatory care visits. Early in the pandemic, that is around April 2020, when patients were reluctant to seek in-person care, video and phone visits increased approximately to 80% of ambulatory care visits. In 2019, a monthly average of about 17,000 members were using remote patient monitoring programs. In 2020, that number jumped almost 90% to a monthly average of nearly 33,000 members. We were able to flip the switch from 85% face-to-face to virtual almost overnight to meet the demands of early COVID, faster than most healthcare systems in the country. This was only possible because of our integrated delivery system and our members' familiarity and comfort with video and phone visits. We shifted nearly all of our mental health services to telehealth to ensure that members, let me mute my computer, to ensure that members receive the high quality mental health care that they needed during the stressful time without risking exposure. In April 2019, 16% of mental health care encounters were virtual, compared to 99% by April 2020. Demand for virtual mental health care services has remained high across the healthcare industry. Throughout 2021, we continued to conduct nearly all of mental health care visits by phone or video to the tune of around 94% of the visits. During COVID-19 pandemic, we saw major growth in telehealth utilization among many racial and ethnic demographics and historically hard to reach populations. Due to the maturity of the KP telehealth program, at the beginning of the COVID-19 pandemic, the organization was able to rapidly adapt to changing regulatory landscape around telehealth. We had no significant challenges in enabling audio-only or audiovisual technologies for somatic and behavioral health interventions. As more people engage with telehealth care, innovation is naturally to follow. We expect to see technical limitations diminish as capabilities expand. It is important that the regulatory framework offers payers flexibility to devise plan designs that enable consumers to derive affordability, access, as well as excellence in care. While it would never replace in-person care altogether, telehealth remains an essential method of care delivery going forward and will help shape the future of healthcare. Thank you. Those are the initial remarks from Kaiser Permanente.
So fantastic. Thank you very much, Davey, for those comments. A few questions for you as it relates to some of the remarks you made. So you noted one of the areas where there was a huge spike was in behavioral health care. And you noted that there was an increase from 2016 to well over 90%, give or take. And we were wondering a little bit if you could talk about how the access challenges might have been addressed and concerns related to privacy and security for individuals that were seeking care, and whether or not you found that there were higher incidences of using audio only for behavioral health, or it was about the same for audio only and audio visual. So those three areas, if you could talk a little bit more about, that would be great.
David, we are going to take this question back to our organization to answer more fulsomely, but our initial remarks would be, we already had an integrated delivery system. Our audio and audio-visual technology is integrated into Epic, and we had time to resolve issues around privacy, at least on our end, well before COVID. So it was not a particular challenge as we scaled access through telehealth to maintain that level of privacy needed for the member on our end. The access consideration, if you could rephrase the question a little bit better for me to understand, that would be helpful.
So I would frame it this way: in rural areas where there might be less comfort with technology, or you might have actually trouble with the technology itself, broadband limitations, how did you approach these kinds of challenges?
Some of the initial ways that I can remark upon are ensuring that we had if we had a telehealth appointment set up, we would have a call or an email to the member to explain to them how to access the app, how to engage with telehealth. So it was really important for us to prepare introductory materials for the member to understand what will happen, how to engage, how to test their system, and the instructions, the step-by-step instructions to do so. And they were also given a phone number to call in case of technical difficulties. That is how we had approached educating the members about accessing care using either telephone only or telephone and video capabilities. However, we can provide a more detailed response after consulting with some of our technical experts in the organization.
And thank you for that. The provider networks are mostly employed providers with Kaiser. Is that fair to say?
That is fair to say.
So my question then would be around the out-of-network providers who were engaging in care delivery. Did you find that there were some unique challenges to these providers who weren't part of the network in their ability to meet the demands using audio only or audio visual?
A number of our partners did step up and enable capabilities pretty fast. However, most of our behavioral health experiences are within our system, and therefore we at present today with me, I do not have a comprehensive way to say what is the experience of out-of-network providers that our consumers faced because of the level of internal services that we provide in the behavioral health area.
I see. Okay. Very good, thank you. So what we'll do is, just to give you a little sense of where we're going, everyone, is that we have two other presenters you see listed on the slide. And at the conclusion of their presentation, we would like to invite others that are participating in the town hall, if there's any particular questions that you might have related to the presenters, or perhaps anyone else who's on the call, it's just a general comment. We would like to invite a bit more dialogue from the group. So with that, thank you, Davey, and we hope you'll stick around and answer other questions as they come up. I'd like to invite Pat to talk a little bit about the perspectives from United Healthcare. Thank you for joining us.
Wonderful. Well, thank you, David. Appreciate it. And Debbie, I'm going to have to follow on some of the comments you had made as well here. So my name is Pat Karen. I am part of our United Healthcare commercial product when it comes to virtual care. So we have a lot of responsibilities when we look at our membership and who we serve in that commercial space, which does exclude Medicare and Medicaid, just to be clear on that aspect there. So as we look at virtual care, very similar to Kaiser, we have been in the space for a number of years pre-pandemic. In fact, we started off back in 2015, 2016 when it came to virtual care and the offerings around specifically urgent care. Our way that we conduct virtual care across our network for our membership is a little bit different from Kaiser. Unlike Kaiser, we're not a closed system. We do a lot of network contracting and partnerships when it comes down to it. So if we look at the core tenets of what it is that we look at in serving our members from a virtual care standpoint, it really is around how can we open up the access of care for our members. We know that there are challenges today with in-person care, if it's within certain medical deserts where that care is not available, or in certain areas where there's simply provider shortages and having the ability to access care as members need that care need. Access is important. Number two, we want to make it simple and engaging for our members. How can we use the power of technology and enable our members to quickly access the care that they need through these digital tools that are out there today, through a mobile app, through a website, through audio-visual, through audio as well. Lastly, there's that component of affordability. And affordability, we look at in multiple different components here. Affordability from the standpoint from the member is how can we drive affordability for them, cost shares that they may have associated with virtual care. If it's within their plan designs, if it's within outcomes from the utilization of engagement through virtual care, we look at all aspects of that. So those are really our three core tenets when we come down and look at the aspect of virtual care. As I mentioned, back in 2015, 2016, we launched our virtual urgent care product to our commercial membership. Now, our stance in regards to our provider partners are in two different ways. When we first started off pre-pandemic, our provider partners were actually national partners. So groups like Teladoc, Amwell, Doctor on Demand were some of our initial partners when it came down to offering urgent care. Because of the way of CMS policies pre-pandemic, local care could only do it in certain circumstances there. Of course, with the pandemic and everything really escalating in regards to the utilization of virtual, a lot of things had changed to allow our local in-network, or actually even out of network, but our local providers in offering telehealth as an option to their members. So back in January 2021, United Healthcare took the stance that regardless of the emergency period associated with COVID, we will allow our providers, our in-network providers, to continue to utilize virtual care or telehealth in offering that to their members where they see fit. So we really leave it up to the discretion of our partners, our provider partners, to offer telehealth within their memberships or not. And so it was really their technologies and everything associated with how they were going to conduct virtual care within their electronic medical record systems, their IT systems and whatnot there. What we did is basically authorize the ability to continue to use telehealth as a means of, or a channel of care. And that was not only for just urgent care needs, but that included primary care, specialties, especially the areas of physical therapy, occupational therapy, and speech therapy. So all inclusive when we look at the holistic nature of the conditions being served under virtual. As we continued, obviously through the pandemic here, and now as we are continuing on nowadays here, we've really opened up our virtual care to be inclusive of primary care and specialist type care that we're bringing to our membership in a variety of different ways here. Primarily through our national partners. So we are looking at a variety of partnerships that are out there today to bring forward these services and capabilities then to our member, where we're embedding that into members' benefits here. But getting down to the core context, it's really around how do we give back and open up the access to our members using the technology as the enablement. So using both video and, where appropriate, telephonic in our ways to access care for our members here. And I'm anticipating some of the questions around telephonic. We only offer telephonic in the areas associated with state regulations allowing audio as part of the channel of getting care. And we do it as a secondary as well, meaning that video is our primary aspect that we ask our members to engage with care, obviously through our clinical experts, along with a variety of other individuals here from a technology standpoint and from a network standpoint here, is that video really is the primary means by which we wanted to conduct virtual visits. But in the secondary case that we have bandwidth issues or can't otherwise, and it does allow for, state regulations do allow for audio, we do go to those means. So we're going to continue to evolve what we're doing from a overall virtual care or telehealth aspect, both with our local providers and ensuring that they can continue to conduct and willing to conduct telehealth, but then also with our national providers in some of the services, capabilities, and solutions that we bring out to the market that way. Just to give you an essence of some of the metrics here, in 2020, about 20% of our overall claims were generated by virtual visits. In 21, we saw the same thing. That is inclusive of both medical and behavioral. Behavioral, of course, being actually the larger component that was driving virtual care, very similar to what Debbie had said from a Kaiser standpoint. But social determinants of health and using that channel of access through virtual is really important in how we want to continue to broaden access. So that's really, in essence, what I have today from a commentary standpoint. I will be open for questions.
Sure. And Pat, thank you very much. Appreciate the information. And we too hope you'll stick around a bit afterwards for other questions. But a few to start off with, and was hoping that you could explain a little bit more what you mentioned regarding the secondary use of telehealth being audio only. I hear that there was the aspect of permissions via regulations in various states. But also, I want to get a bit more understanding of where does the consumer fit. If a consumer says, I'm not really comfortable using telehealth for audio, I would prefer to use a video. Does that enable the provider to then use audio only, or is there a process where first they have to use audio only, it fails, video and audio video, and it fails, and then they go to audio only? Or is it their discretion for the consumers to state their preference and for providers to honor that?
Yeah, absolutely. And I'll answer it two ways, because there's actually aspects of both on that, David, which is number one, in all of our communications with our membership, we do urge the use of video as the primary means to conduct a virtual visit. And that is for obviously various reasons from our clinical clinical team saying you are going to have better outcomes associated with visual cues and that discussion with the member or the patient. And if there are technology issues, then we go secondarily to audio only. However, it is upon the discretion of some of our providers if they want to do a virtual visit or telehealth visit via audio as well. Members do have that ability to make that selection, again, in states that do allow audio visits to go that way, but it is not a preferred path, at least in the way that we communicate to our membership.
And could a consumer then, I believe I hear you say that a consumer could say, my preference for a behavioral health session would be to use audio only. And when I schedule that appointment, I could indicate that during that time period.
Correct. With some of our providers, we have the ability as a selection to say, will this be audio or video? Correct.
And you mentioned about the percent of use of telehealth in 20 and 2021, and it sounded like you were indicating that there wasn't much change, about 20% overall, or did I misunderstand that?
No, you're absolutely correct. It was 20% overall, which is a large part of, as of 2020, huge part. Obviously, that was the peak of the pandemic, but we thought there would be fall off in 21.
Yeah, that's exactly right.
But we didn't find that in the way that it came through. Now, again, a lot of our local providers were offering telehealth as well. So you have the combination of both local and national providers together that still drove the same level of claims that we did in 2020 versus 2021. So great to see.
So the measurement is a percentage of claims as opposed to a measurement of providers that are using or engaging in telehealth.
That's correct.
Interesting. And how about the national networks? Because there's, they exist for support for telehealth for primary care and some specialties. Was there a ramp up in volume as well, or is this measurement predominantly driven by the networks that you have, the provider networks?
Yeah, great question. And really, when we say the majority, I want to talk about the vast majority of virtual care was driven by our local networks versus our national partners. Now, we did see a little bit of a fall off from our national partners between 2020 and 2021, but again, it was picked up by our local networks then that took on that continued role of offering virtual.
And for the providers that you have, did you get feedback regarding concerns around its use? Did they feel like it was equivalent, the use of telehealth was equivalent to in-person, or were there providers that said, look, I'm using it because United Healthcare says I have to make this available, or I, air quote, should make this available, when in reality, I'd rather not use it?
It's a fair question, and I would restate just a little bit that to say that we don't ask our network to offer telehealth. It is still up to them as individual provider groups to offer it or not. So there's definitely a level of comfort within each of the practices that are up to them. However, when it comes down to the use of telehealth, what we've been hearing back primarily from our in-network providers is that for the most part of it, they found it convenient. They found it as a way that they can actually better enable their population, their clinical staff appropriately. So, a great example, and I've heard this a couple of times, is that you have providers that may go out on, I wouldn't even say vacations. They would just be other places, but they could still conduct a panel, knowing that they're licensed within appropriate states to conduct virtual care. So they had the flexibility to continue to offer that piece, and they found that actually to be a positive when it came to their own clinical staff. As far as from a membership standpoint, there were initial thoughts that members may think that a virtual visit wasn't as high of a quality as an in-person visit. However, through a lot of our surveys and assessments that we've conducted here, we didn't find that that was necessarily the case, that actually members thought it was really convenient, it was very easy, and they will continue to use the service.
And have you heard comments from physicians in your network regarding concerns about telehealth, where particularly they might have a practice, the practice might be near a border state where their patient population could come from across state lines, and concerns about from physicians or the practices themselves being unfamiliar with or unclear about what's permitted and what's not?
Yeah, there's definitely issues, concerns associated with those from a border standpoint there. So we can offer guidance at best. Some of these clinical groups actually even licensed in that other bordering state potentially to make sure that they have then that right coverage, knowing that some of their patient population could be over in that other geography. So we do hear that it is a concern, and I think that's where some of the alleviation with our national provider network can also help with that in the licenses that they have. So there are concerns. I don't want to not say that there isn't, but they do try to work through it the best they can.
So one more generic question, and again, we'll hope you'll stick around for us to have some more broader questions from the group, and that relates to the speed at which United Healthcare ramped up. You had mentioned that you had launched some of the telehealth initiatives back in 2015. Do you think there were, in retrospect, once the pandemic arrived, if there was something you might say, look, when we launched telehealth in 2015 and we had it going in 2016 and so on, we didn't account for it when we hit the pandemic. This was a failure point, and if we could do this over again, here's what we would do. Whether it's a technology platform, whether it's a policy approach, was there anything you looked back and said, gee, if we could do this over again, here's what we would do?
That's a good question. I think going back to that statement here, I think we were well positioned, at least from a national standpoint, in serving our membership appropriately here. Where I would say is from a local network side, that's where a lot of our provider partners had to ramp up very quickly. They were not necessarily ready in most cases to take on telehealth as a channel of care. And I would say, hindsight is always 20/20, of course. Could there have been things done pre-pandemic in the preparation of the utilization of technology and the engagement of an adoption really from our provider partners and members in utilizing telehealth, so that when a pandemic like this would have occurred, it would have been second nature, where people would have used an alternative path into care like telehealth versus having to pivot very quickly and actually see some of the delayed care that we did see because just the technology wasn't ready to take on care appropriately.
And I do have one more lingering question. Sorry, I think I could continue asking you questions all afternoon, so I'll be mindful of everyone's time. But I'm curious about how your organization is viewing parity around these kinds of services. Is there any difference in your mind or the policy minds of those at United Healthcare around care that's delivered virtually versus care that's delivered in person?
There's a lot of a couple of things on that one. In regards to parity, I think you can look at parity as far as the service is concerned, there's not necessarily the clinical overhead associated with necessarily having a telehealth visit. Could you argue that parity should be less than an in-person visit? I think there's going to be an argument for that side of it, but looking at the provider side, they're still providing clinical care with the same staff that they have on hand to offer clinical services. Doesn't matter if it's in person or if it's telehealth, it's still the same type of care. So you could see arguments on both sides of the parity example there. And I think obviously we will continue to work with CMS guidelines and what that dictates as far as what we're trying to do, and work with the parity laws as appropriate. So I know it's a very vague answer on that one, but at the same time, it's a very sensitive area that we want to be careful with, and also, of course, appreciate both sides of the argument.
Yeah, I think I heard I'm hearing all the providers cheering in the background about your comment around level of services related to care that's delivered virtually being similar to that which is in person. But so it does sound like you're using the CMS guidelines as a bit of a benchmark to how you're looking at telehealth for services as well as for reimbursement. I believe I hear you saying that.
That's correct. So obviously we abide by the parity laws, and then wherever possible, CMS guidelines.
Wonderful. Okay. Fantastic. This has been extremely informative. Thank you very much for your remarks. I would like to turn to Neil. Are you able to unmute your phone and join in the discussion?
Yeah, David, can you hear me okay?
Indeed. Welcome. Thank you for joining us.
Sure, I appreciate it. So first of all, good afternoon. My name is Neil Karkanis here on behalf of the League of Life and Health Insurers. Thank you for the opportunity for me to make a few comments today. Unlike Pat and Davey, my comments are far more high level. So if there are any specific questions, I'll certainly bring them back to my members for feedback, but I'm really appreciative of being part of the conversation today. And I also want to apologize for being off camera. One of the many distinct pleasures of living in Baltimore City is a BGE is perpetually working on my street. So my connectivity is a little weak today. That being said, first of all, telehealth expansion was appropriate and it was necessary to meet consumer needs during the pandemic. I think in some ways it was a blessing in disguise because it allowed us to ramp up these efforts, and it's been really useful to consumers. It's undeniable how valuable the services were and still can be. Though we know utilization was quite high during the pandemic, we know that it's dropped off significantly across the board as the world has gotten pseudo back to normal. That being said, because of a variety of factors, we know that we are going to see an increased desire to have telehealth as a baseline tool for care, which I think we all can agree is appropriate for some situations and specialties and not appropriate for others. I'll quickly add that we would agree with Davey's comments that it's important to maintain flexibility in plan design. This will help ensure that people can get the services that they need at an affordable price. The League is looking forward to seeing the data analysis from the MHCC study to help us shape public policy moving forward that meets the needs of the population. We do hope that the report is mindful of the financial impacts to premiums. Finally, as we appropriately utilize and embed telehealth as a core part of the healthcare delivery system, just one thing I may have missed, but I haven't heard yet, is we should have this care captured into the network adequacy regulations. It's especially important as we continue to modernize the healthcare delivery landscape. So that being said, my comments are short and sweet. David, I appreciate the time and I'm here for the discussion.
Yeah, thanks, Neil, for those remarks. Could I invite you to start out by helping us understand your point about network adequacy? I heard that, but I'm not sure I understood exactly what you're aiming to know.
Sure. So carriers are required to meet network standards and adequacy, geographic type of services, et cetera, available in the state for consumers. And the MIA captures this data regularly from carriers. And we just want to make sure that as telehealth is expanded, for example, for behavioral health services, where we hear anecdotes that folks are unable to access services for a variety of reasons, if there's telehealth services available for behavioral health, for example, we believe that those services should be captured in the network adequacy regulations, i.e. those are services that are available through the networks.
Okay, understood. So thank you. As I'm asking Neil a few questions, I would invite the participants. You've heard a little bit from Davey, Pat, and Neil. And we also have some other carrier representatives here today. If anyone would either like to make comment or just ask a general question, I think we have some time that we could do that. If it works, please use the hand raising option, and the team of MHCC will be on the lookout for any hands. So let's just go back and ask Neil a couple more questions as it relates to utilization. One of the observations you made was that there was a fairly large, significant drop-off in the use of telehealth recently. And what I heard Pat mention was that it's been somewhat consistent across the board for United Healthcare. Are you seeing pockets specifically related to a carrier, or are you seeing pockets specifically related to geographic locations that's helping to formulate your observation?
We've seen it, at least from the trade group's perspective, we've seen it far more broadly, not necessarily carrier specific. So for example, when the pandemic occurred, that was the only place that people can get health care services. And now folks are going back to the doctor in person. So as a result, we're seeing a drop off broadly, but I don't have any specific data right now.
Okay, very good. So let me invite, we have a question, but I don't seem to have the option. So Kathleen Logren, if you wish to unmute yourself, just sort of do an introduction of who you are for the 35 folks on the call today, many of which I'm sure know you, and then please ask your question.
Thank you, David. It's good to see you and good to see and or speak with everyone else here today. I appreciate the time. So I'm Kathleen Loughran. I have government relations and business development for the Northeast for Elevance, which was previously Anthem, and that includes our affiliate AmeriGroup, specifically AmeriGroup Maryland. We are one of the larger MCOs operating statewide in Maryland. And I just wanted to make a couple comments, particularly as they relate to Medicaid, but I think they probably affect other markets as well. We have been very active on the federal level in efforts to make permanent many of the provisions that were adopted during the federal emergency. And of course, there are several pieces of legislation pending before Congress, many or most of which we are supportive of. And I think the question that was posed when this meeting was scheduled, and certainly when the conversation occurred a couple of weeks ago, is what barriers exist to accessing telehealth or virtual care. And I think from our perspective, the largest barrier at this time is access to broadband, particularly rural areas and underserved areas. We have concerns that were expressed by the previous speakers regarding audio only and its effectiveness in maintaining that standard of care that our members deserve and expect. And we would agree that continuing audio only at this time is appropriate, and studying the continued use or permanent use of audio only is also appropriate. But I think that we probably need to look at what the standards might be so that there is equal participation by all providers in the use of audio only and audio visual, but particularly the audio only component. I think, David, you raised a good point. Members should always have access to virtual or in person if that is the member's preference. But focusing on broadband and providing that across the board in many areas of the state would certainly enable more people, members and providers, to have audio visual experience when using virtual. And I think the other barrier that we had seen but has been addressed certainly in Maryland and has been addressed at the federal level under the pandemic, but we would like to see permanently addressed, would be removing those geographic restrictions that currently exist for organizations to serve and to allow the home to be the designation of the medical place, if you will, so people can access from their home without question as to whether or not that would be appropriate under the guidelines that exist for telehealth, particularly once the emergency passes.
So Kathleen, thank you for those remarks. Very informative. I would like to bounce back to the standard of care concern that you raised. And I'm wondering, are you seeing, is it your experience or opinion that there are variations for somatic and behavioral health relates to the use of audio only? And I say that because, interestingly enough, one of the things seems to resonate in my memory from the provider panel last week was that for behavioral health, it seemed like consumers, from the perspective of providers, really appreciated the use of audio only as an option rather than, say, a fail first using audio visual before you use audio only. And it was interesting because I hadn't thought about or heard before the concerns that consumers raised around having the healthcare therapist look in, if you will, to their surroundings, and it didn't create. They felt insecure about having folks look at their inside of their home, where they're at. And so what comes to mind is that on the behavioral health side, there was just a huge question about permanency and the views of individuals related to audio only as a feature or option for behavioral health. Any thoughts there?
So I think that virtual or telehealth care has really been an access, and has really created a great deal more access for people, particularly with behavioral health services. I think that one of the things that we have been supportive of, particularly at the national level, is retaining certain flexibilities regarding the prescribing of controlled substances for medication-assisted treatment for substance abuse disorders. And I think that that is something that there's been a push, certainly at the federal level, to try to make permanent, so that once you have the expiration of the federal emergency, that would continue to be there. I think that rural health clinics and FQHCs and designating them as distant sites for telehealth has been helpful. And I think that is something that helps both with somatic care and behavioral health care, but particularly behavioral health care, particularly if some of those FQHCs are partnering with very specific driven mental health providers. So those are some areas that I think that we're seeing some benefits. We are not getting any complaints from members or providers, frankly, about existing barriers to care. I think the concerns we hear from time to time from certain providers is to make sure that we would continue to honor some of these provisions. And of course, under Maryland law, we've extended everything that was adopted under the federal emergency until at least, I think, 2024, so that this group can have a chance to vet what works and what doesn't work and come back with certain recommendations.
Okay, thank you very much. Hopefully we can encourage you to stick around in case there are some other questions that you might be able to address. We do have a hand raised from a representative from Kaiser. I can't see who it is other than the name. Oh, Davey, please proceed.
Hi, David. I wanted to reiterate the point raised by past speaker as well as Neil, which is that for behavioral health, telehealth does increase access significantly. And we have seen that within our own practice. In addition to that, what we also notice is that our members do prefer to have video visits, and it increases the ability of the member to connect with our provider, as well as the provider to see things about the member than what you would collect during the audio. So it goes both ways in terms of building confidence and the ability to understand circumstances. So it is important that there is some amount of video coverage. And it is also important to consider that telehealth increases behavioral health access.
Yeah, wonderful. Thank you for that. So I have a general question for, I would say for Davey, Pat, Neil, and I think Kathleen. And that's related to a comment that Pat made regarding the CMS policies around telehealth have been sort of a beacon for how United Healthcare has approached its telehealth policies, both for care delivery and reimbursement. And I'm just curious what the group thinks about those kinds of policies. Is it a good idea to have a standard set that is pretty much driven, at least as a framework, by CMS to build upon? And Kathleen, your thoughts?
So I think certainly in the Medicaid program, and I suspect likely the Medicare program as well, that is something that's very valuable and is being looked at on the federal level through several pieces of legislation that look to standardize and specify delivery of telehealth services in those programs under certain circumstances. And that might be something that Maryland can look at as a guide, whether or not we want to adopt it within Maryland, regardless of whether or not the feds are able to be successful in passing something, or if we believe it just makes good sense to provide whatever is being provided at the federal level. But I think particularly when it comes to the Medicaid program, it's important that the state who pays for these services ultimately, who contracts with companies like Amerigroup to provide the services, and then the providers who actually administer the healthcare, everyone is on the same page as to what is expected and required to be provided and what is being paid for. And the members then have a clear understanding, regardless of where they seek their care, what they are entitled to have and what that will look like.
Interesting. Okay. Thank you, Kathleen. Davey, your thoughts?
I have to differ because we do want to think about this internally in the organization before I respond to this, David.
Okay. No worries. If it's more a question of general thoughts. So if you have a view, that's fine to share it. If you choose to defer, that's also fine. And how about Neil? Any reactions or comments here?
David, I'd have to agree with what Kathleen said, especially on the Medicare Medicaid side. I think, as we look into parity, payment parity, that's obviously going to be the big question. Pat brought it up as well. And the policy question and argument is simply going to be, do we consider video to be the same as audio? Do we consider video to be the same as in person? And that's going to be a policy question for this group and for the legislature to take up. We would obviously say that, that parity in a virtual setting and an in-person setting is going to have an effect on other things. So those are just all considerations that this group needs to have as they look at it.
Yeah, I appreciate that. Thank you, Neil. So perhaps I could pollinate a little bit of the conversation with a provider perspective. And Ellen Weber, could I invite you to make a few remarks based upon what you've heard?
Hi, David. Thanks so much. I'm not a provider, obviously. And so I can't comment from that perspective. And more than any comments, I do have a few questions that I would like to raise, if that would be appropriate.
Sure, please.
Okay, great. Thank you. I guess a few of the questions, and this picks up a little bit on what Neil's comment was with regard to network adequacy, because again, in Maryland, we all know that that is also part of MHCC study. The MIA is supposed to take a look at how network adequacy should be taking into consideration these telehealth considerations, or the telehealth services. And so, and they've now put out a proposed rule in which it's a draft still, but they are asking some very specific questions around that. And so I do just have, you know, some basic questions regarding what the pairs have already talked about, and just if I could offer a few of those.
Sure.
So one of the questions that I have is, again, and this came up a lot in the provider town hall. It was clearly the appropriateness of the service was, again, a clinical judgment in collaboration with the patient. And I think that was their guiding force. And so, or their guiding mantra, obviously, as we all think that that's appropriate, right? This is a care decision. And so I guess the question that I have is, how are carriers taking that issue into consideration in terms of what is appropriate, right? Care that can be delivered through telehealth. How are they factoring that in? I wanted to find out, the second question is, you know, in setting appointments right now, are there any differences between how the carriers are working with their providers in terms of trying to either direct individuals who have behavioral health needs to one form of care or another? Since again, there has been this understanding and recognition that telehealth has really opened up the availability for individuals to get behavioral health care. Is there now some assumption that payers or providers are working on that says we think that's where patients want to go? Are we going to be directing folks in that way? So I wanted to find out whether there are any different practices that are being put into place on the medical side for any particular specialty versus on the behavioral health side, given that, you know, history over the public health emergency. And then the final question that I have is, you know, what data right now are the carrier or the payers really developing? Because I know obviously they're tracking this very carefully, but what data are they looking at to determine in Maryland where telehealth services are available, where they're accessible, and where they're appropriate? And so what data sets are they developing? What will they be able to present to make the case, you know, as we're making these policy decisions?
Yeah, that's a lot of good questions, Ellen. Thank you. So let's see if we can unpack a few of them. We might not be able to get questions to all of them here, but why don't we start with Pat and see if we can address a few of them, and then Kathleen, if I could also ask you to be on deck for to try to address some of them that you are able to as a second, and Davey third, that would be great. Pat, your thoughts?
Well, wonderful. Ellen, a number of nice questions there. I'm just wondering, which one do I start with here? So I think what I'll do first is I'll actually probably hit your second question, which is your question really around behavioral clinical access. How do we direct members to the best form of service, I guess you could say. And for us, it's really laying out for the members, in our case, what are the members' options? It's still up to the member and how they want to conduct their care. What do they feel comfortable with? And then, of course, from a clinical standpoint that you mentioned is part of your statements then, which is the best route for care. So we make our members really understand that virtual is an option, but we don't necessarily, I guess you could say, steer a member to a virtual care practice. It is still up to their discretion if they want to do. What we do is we acknowledge within our network, for example, which providers do offer telehealth care, and that's based on their responses to us. Number two, we do make aware what services are available via telehealth as well. So again, the members are understanding back to the points of access and scheduling. We know that in certain circumstances, if with our national providers, as a great example, they may be able to get into services in days rather than weeks. So again, it's just making sure that they're very well aware in our communications, not only with our digital tools that we communicate by, but with our advocates, our call centers who engage with those members as well. So really is about education, and then they can guide as appropriate. The other piece is the appropriateness of care. There are certain conditions that you can treat virtually very nicely, and there are some that are just not appropriate at all. Of course, that is all based on clinical discretion and how we have our clinical providers work with the members appropriately. So we could say, for example, for urgent care, members with skin rashes and pink eye and some of these other things, very low acuity, may be best suited for a virtual type of care. Please consider that. Of course, if a member thinks that they have a broken arm, are we going to say virtual care is the best? No, not at all, right? We're going to have them go into the appropriate care from there. But we do state that there are a number of conditions within the portfolio that may be conducive to care. And we, again, just offer that from our education standpoint there. So I think that hits a couple of the questions here, and I don't want to take up more time here, but Neil, Debbie, I don't know if you have responses as well.
So, so why don't we go to Kathleen, and then Davey, you could come in behind, and then we'll turn to Neil.
Sure, David, thank you. I think, Ellen was asking this of the carriers, which implies the commercial market, not the Medicaid market. So my answer is going to be brief and probably not unexpected, but for most behavioral health services provided to Medicaid members, that is provided through a carve-out program. So the MCOs are not responsible, and that's really an area that would need to be answered by the ASO or the state directly. What I can tell you is that for certain primary mental health services, very often the PCP is the point of contact for the member. And many of those visits are occurring in person again because they involve examination. And at that time, the primary care provider does ask whether or not the member is experiencing depression or anxiety. Members can certainly make virtual appointments with their PCPs if they're having a particular episode, whether it's physical care or perhaps anxiety or depression, and then it's up to the provider to determine whether or not that's something that needs further examination. And if it does, very often the provider is then recommending that person go to a specialist, which again would put them in the carve-out situation. So hopefully that answers the question.
Yeah, very, very well. Thank you. So Davey, your thoughts?
I find myself and our organization particularly aligned with what Pat had to say earlier. It is very much up to the member in conjunction with their provider to decide how they seek care. We enable them to make their decisions in conjunction with their physician. So when a member calls in and describes the situation, we offer them both telehealth or in-person visits, and they can choose. As Pat said very rightly earlier, during the course of the conversation, it could be things like a suspicious mole or a broken arm. Those cases, a telehealth visit will not be appropriate, and therefore, in those kind of circumstances, we would encourage the member to have an in-person visit. However, the guiding principle for us is that the member and their provider determine the right venue of care and the right type of care that is needed for them.
Yeah, very good point. Largely we're hearing that, on a consult, there's greater likelihood that there's options, but where there's a procedure that needs to be performed, there's less likelihood of trying to have a telehealth visit, and that there's more emphasis on scheduling for an in-person visit. Neil, your thoughts?
David, I don't really have much else to add. I mean, I think this ultimately winds up being a carrier-specific answer, and I think but from the two carriers you've heard from in the commercial market, they have basically the same answer. But I'd be happy to share the questions with our members and circle back.
Yeah, no worries. Thank you for that, Ellen. Great question. Appreciate that. Are there other comments from attendees that anyone would wish to make? And as you're thinking about it, let me sort of just tee up where I would like to get as we approach the wrap-up session, a general question as it relates to what's the future look like? And I believe we've heard from a number of the presenters here today, both scheduled and ad hoc, what their preferences are in terms of how telehealth is driven today and what it might look like in the future. But I'd specifically invite the carriers, the representatives, to talk a little bit about what they see as an ideal future state for telehealth. And it can just be a matter of your opinion. You can base it based on anecdotal data. You can look at it from some empirical information. But let's just sort of talk about what's that vision look like for you or your organization. So Pat, I'll put you on the spot to go first. What are your thoughts?
That's a great question, and I'll state it this way: take it as my opinion, and only take it from that standpoint here. But basically, I think it's going to be the continuation of centering on the member, on how they can continue to access the quality of care for a variety of their needs. So today we've talked about everything from urgent care to primary care to specialist type care, but there's going to be that continuation of that evolvement into using artificial intelligence and better utilization of data. So Ellen had asked a question about data and where is that going there? I think we can have better understandings of how to better engage with members through proactive data assessment here. There's the continuation of remote patient monitoring and remote patient vitals. There's at-home labs. There's a variety of things that are coming out new that can help surround and supplement that whole area of care. But again, it gets down to the core context of this is a decision upon both provider and member in how they want to conduct the care and where is it appropriate via telehealth, via these other areas that are emerging, and how they effectively conduct the care that they need for the ongoing care for the member. So I think we have really a wide open field when it comes to the future of care. It's a matter of adaptability, where technology is going to help enable it, and then is it going to be leveraged correctly to conduct the care at home and really make it convenient for the member and for the provider.
Yeah, very good. Thank you for those remarks. Davey, your thoughts?
My thoughts are in alignment with Pat said. The member needs to be at the center of the telehealth of the future. And we need to work in ways that reduces the friction for the member as they engage with various care needs. And currently there are multiple types of friction that is in the market. And one of the areas that we think is, at least in my personal opinion, is important is that the member be able to maintain the relationship with their provider, regardless of where in the United States they are, because that offers them the best continuity of care. And today's regulatory environment might not enable the member to have that kind of experience. In addition, as the telehealth capabilities improve, we would see more of patients using remote monitoring, data-driven healthcare delivery that delivers help even before a member is aware that they might have a care need. And to enable all this, a fairly radical future, what is really important is a framework that is a regulatory framework that is flexible, that allows to reduce friction for the member in engaging with the care team that they want to engage with.
Yeah, well said. Thank you very much. Neil.
Sure. So, I mean, I'll just say first off, there's a lot of providers out there that still haven't embraced telehealth fully or at all. So I think we need to get a sense of, that group of providers and what we can do to get them to embrace it or to find out if they will at all. That being said, we also, like Kathleen said, need to ensure that we expand broadband broadband internet services. Otherwise, there's no means for us to provide telehealth in rural areas, and we won't be able to maximize this incredible tool. I'll just mention that as far as I know, remote patient monitoring is still seen as a medical device in Maryland. I don't think it's linked to telehealth. So we need to look at how to link those two things. It's probably not as easy as we think, but I'm not saying it's not very useful. That being said, broadly, it's really exciting that telehealth provides the means for people to access appropriate services that they have not been before. And I think as they're able to access that services, I just want to reiterate that we need to make sure that we capture it in the network adequacy regs.
Yeah, great point. Thank you for that. So Jenny Azor, I haven't reached out to you, but I think if you can unmute and you're able to come on camera and you could contribute to this question, that would be great. Are you available?
Sure. Thank you for the invitation, David. It's all right. I'm gonna stay off camera. But thank you for the invite. I am a policy analyst at Care First. And in terms of what I see as the ideal vision for telehealth, I think definitely making sure that we are, and this is just my personal opinion, making sure that we are centering the patient and also considering the appropriateness of care. And as many have said, making sure that it's a collaborative decision between providers and the patient in what is the best mode of care they would like to receive. And also centering equity as much as possible, which is really needs a focus on infrastructure and improving access to broadband. But with the affordable connectivity program that the administration recently released, that definitely is hopeful in terms of increasing broadband access to areas that don't have it.
Wonderful, thank you. And Kathleen, your thoughts. And I would ask that as we get close to the wrap up, I would like to invite Diana Lynn Sue to make the final remarks from the provider perspective, specifically from the hospitals. So Kathleen, your thoughts.
So thank you, David. And I don't want to repeat everything that I said earlier on, but there are some very specific provisions that we think would be ideal for us to be able to continue and further expand on the use of virtual care. And that includes removing geographic restrictions and removing in-person requirements. And I think Neil touched on it. There are some practitioners who may not yet be comfortable with virtual care, or frankly, may not feel that they are equipped for that. And again, that is where the expansion of broadband connectivity can help to improve access and affordability and ensure that even though care is being provided virtually, it is still quality care and it meets the standards of care that have been developed for those services. I believe that the audio only is probably the most difficult discussion to have, given that some may view that as a last resort in providing care to an individual. And ideally, you would want the audio video, but again, that's going to depend upon access to broadband, particularly in those areas, those rural areas, underserved areas. And for me, working for a company in Maryland that serves Medicaid, I think it's really important to make sure that access to care is the same whether you are being served in the commercial market or the Medicaid market, or frankly, the Medicare market. But certainly Medicaid patients should have same access to virtual care that commercial patients do.
Okay, very good. Thank you. Those are very instructional comments. We appreciate it. Diane, are you able to make a comment?
Sure, thanks, David. I'm also going to stay off camera if that's all right, but appreciate the opportunity to comment. I'm Diana from the Maryland Hospital Association, and we just really want to emphasize that, that we really view telehealth as an equity issue. It is really, especially around audio only, and of course, in many aspects, parity, because that also contributes to the willingness and the ability actually for providers to provide telehealth, because there are many different types and different layers of requirements in order to be able to deliver that service. So I don't want to really to reiterate many of the things that our providers have spoken about last week. I think a lot of those same points really stand. The only other thing that I could focus on for telehealth is that we also view it, in addition to the equity standpoint, we view it as a tool for workforce. And that is I don't think we've heard that, or we've heard a little bit of it today about some areas where there are provider shortages. But we really see telehealth as a way to also be able to expand the capabilities that we have, whatever existing capabilities we have, and to find new ways to allow for appropriate avenues of allowing our providers to really serve at the top of their licenses.
Okay, wonderful. Thank you. So we'll continue moving. We have about, looks like about 8 minutes, give or take, on the clock, and we want to be mindful of everyone's time. So, Nikki, why don't you take us through to a couple of the other slides, and then we would like to, as part of the wrap up, invite our executive director to make some general comments to the group, and then I will bring up the rear. Thank you, Nikki.
Sure. So as I had mentioned earlier, we welcome any written comments for those who may not have spoken today, or even if you did and you want to send your written remarks, you can send them to us. Actually, it looks like we're accepting them until July 28th. I had misspoke earlier, so you have a little extra time if you feel the need to send them, and you can send them to myself or Christine Karianopoulos. Her email is listed on this slide. And then we will, of course, send in the coming weeks a link to this recording and a high-level summary, and those who attended, as well as the written comments. I'll pause here. Thanks again for your contribution. Ben, are you able to join and add anything?
He may have had to step away, so
I just came back. I don't have too much to say. Again, thank you to all of our speakers for sharing the thoughts and perspective of their organizations. I mean, I think one of the things that I am not certain I completely buy into is the equivalency of that we're trying to make on audio only. For it's an alternative, oftentimes a less desirable alternative, but an alternative. And I think research needs to be done on just how efficacious audio only is in the entire scope of services where it can be delivered. That's a different measure than should it be delivered. We hope to shed some light on that as we move forward with our various studies. But thank you very much, everyone, not only speakers, but attendees for their attention. And I'm sure if you have comments, David and his team will welcome all of your thoughts. So have a good afternoon.
Thank you, Ben, for that feedback. And to everyone, I echo what our executive director said, and we appreciate your time and your dedication to this very important topic that we've been working on for a while. And we look forward to engaging you as we move forward. So with that, I wish you all a wonderful afternoon, a great rest of the week, and we look forward to talking to you again soon. Be well, everyone.